Okay.
Oh crap, I didn't mean to do that big.
Couple things to go over. I'll do the exam review at 3 on Monday because everyone has taken it. So if you want to come early, you're welcome to. Then the link for the HESI RN case study is still broken. I submitted a ticket in the first week. So what I'm going to do is today I will take all the questions and put them in a Canvas page rather than a link to another website. I'll just practice my typing skills or my cut paste. So it'll still be the same due date because, I mean, I can extend it a day or something because you didn't have a day. But yeah, sorry about that. Yeah.
What did you extend?
So I can extend the day, 1 day for the due date for this case, HESI RN case study.
Not the one that was 4 questions?
It's the one that's the HESI RN case study sleep, and it goes to the HESI preparation suite, except the link is broken. Yeah. So it should, does it show up on the calendar?
Oh, no, there's something that's-
It should, because it has a due date.
Oh, for week 5,
Yeah,
Oh, that's why.
the sleep pattern.
yeah. Oh, it's raining. Yay. All right. So we're still in chapter 15. We're in the central nervous system stimulants. And we're going over weight loss drugs. So the mechanism of action of the class that we're talking about is an adrenergic, sympathomimetic, and adrenergic agonist that suppresses appetite. The drug I chose was phentermine. There's phentermine with topiramate. Both of them are structurally related to amphetamines, but less abuse potential. So we are stimulating the sympathetic nervous system to release norepinephrine and dopamine. We'll get to that system next week, or yeah, next week, probably Thursday next week. It acts on the brain to suppress appetite. That's the take home from phentermine. Let's see what we got. Yeah, because it's a CNS stimulant, all of the same adverse effects apply. You stimulate the central nervous system, you get tachycardia, palpitations, high blood pressure, increased anxiety. It's just what you would think if you took an upper. This is still 13. So yeah, I wanted to finish because it also has migraine. So here's a question about a patient who wants to take orlistat, and that should be a small O, not a capital O, because that's the generic name. Isn't it? No. Orlistat is a brand name. Anyway, to assist their weight loss program, but they're wary of its unpleasant side effects, what measures can be suggested to reduce these effects? So you have to recognize what is orlistat, what's the mechanism of action, and that tells you the adverse effects. So this is not a stimulant. Anybody remember reading about orlistat besides Nestor, Anna, Victoria, Susanna? So should be on your radar that so orlistat is the prescription version of the over-the-counter medication Ally. Its mechanism of action is to prevent absorption of fat within the gut. So you can imagine if you're not absorbing fat in your gut, you're going to have oily stools. And that's the adverse effect. We have oily gas, oily stools, and so fecal incontinence. The wet farts, they're known as. And so what you teach a patient is to restrict their dietary fat to less than 30% of total calories in order to address that adverse effect. So if you know the mechanism of action, you can kind of deduce what the adverse effect is. So let's see. So this is these are other drugs. They're not the stimulants. There's that orlistat, which is a non-stimulant. There is naltrexone combined with bupropion. Where did you see naltrexone before? came up in the chapter with naloxone and naltrexone. So this is a weight loss. There's also GLP-1 receptor antagonists, which initially they are injections given once weekly. They initially came out as diabetes drugs, but they found at higher doses they act in a different way. So they, let's go back to orvostat, binds to lipase. So that's the enzyme that breaks down fat, right? And so I guess I put one for each one. So this is the mechanism of action, right? It binds to the enzyme that would break down fat, thus preventing its absorption into the bloodstream. We teach them to restrict fat by to 30% of calories. So if you're not absorbing all the fat in your food, you may not be absorbing fat-soluble vitamins. So typically teaching them their A, D, E, and K, they're probably going to need to supplement with. So this is the GLP-1 receptor antagonist. This is Ozempic, the drug on the market that's super famous now for weight loss. All the Hollywood stars use it. There's actually a shortage on it, so people with diabetes are having a hard time getting access to the medicine because it's such the fad now, but it is effective. So the way it actions is to mimic a naturally occurring hormone that's released in your gut in response to eating. And that hormone acts on your brain and your gut. It tells your brain that you're satisfied and it slows the movement of your gut. So you feel full sooner and you stay full longer. It's kind of a cool mechanism of action. Here's a question of patients prescribed an anorexiant. Do you recognize what that term is implying? Which statement will the nurse include in a patient teaching? Take it with your evening meal, take it for 2 years, develop a dry mouth, stop taking it immediately, avoid caffeine. So what were the anorexiants? What is an anorexiant? All right, think of anorexia, like it's an appetite suppressant, right? They were stimulants. They were central nervous system stimulants. Remember what chapter we're in. So these are central nervous stimulants, so that should help you deduce which of these probably is correct. If it's a stimulant, would you want to take it at bedtime? No. Yeah, we're not telling people how long they're taking the medicine. So what's caffeine? Right, so synergistic mechanisms of action. People do it anyways, but that's what you tell them. And then we don't tell people to abruptly stop because you get rebound appetite. That's the last thing they need is to start eating and regain all the weight they've lost. All right, went over that. Migraine, all right. So this is also in the chapter on central nervous system stimulants, interestingly. So the definition is this chronic recurring headache that's from 4 to 72 hours. These are the classic features. It has this pulsatile quality, typically one-sided, but can happen both sides. And then all of these associated symptoms that make people miserable, not just the pain of the headache, but the nausea, the vomiting, the sensitivity to light, sensitivity to sounds. And then this phenomenon of aura, which really is something that I can't describe because I haven't had a migraine before. Everybody ever have a migraine with aura? What's the aura like?
Feels like this feeling that you just want to sleep, or either like you're about to puke, or
Okay.
you're about to have a nausea bomb.
Okay. What's your experience?
Mine is I can't see. It has to be no lights and everything, but it just feels like this, like you're in this ice. And
Another feeling too sometimes is when you wake up, you're starting to have a migraine. I think that's the worst feeling too.
I can imagine. That's the last thing you want after you sleep. You want to wake up and feel rested. All right, so these are the primary drugs, the first line drugs for treating a migraine. They are called 5-HT receptors, but we never call them that. Nobody calls them that. They're called triptans. And that's because all of the ends of the words end in triptan. Sumatriptan is the most common drug on the market. So what causes migraine typically? Or, I mean, most non-muscular, vascular type headaches, what's happening in the blood vessels? Vasodilating. Headaches are caused by vasodilation, theoretically, in a closed box, right? Our skull is a closed environment, and we are increasing the intracranial pressure slightly by vasodilating. That's the theory of it. So triptans are used because they vasoconstrict, and they'll bring that blood vessel back down to its normal diameter. It does have some anti-inflammatory properties, and it's used as an abortive therapy. What's an abortive therapy? What does that term mean?
Like, can get rid of something.
Right. It's not a prophylaxis, it's not a prevention, it's something that's to terminate it. So it doesn't mean you're going to have an abortion. It means that it terminates the headache when it happens. All right, so let's see. Triptans are great drugs. All right, that's a lovely one. So these are there may be more triptans on the market. These are the ones that are more common, but they keep coming out with new ones every day because every time they make a new drug, they can make it a brand name and get a higher price. This is the prototype. It's the original drug, sumatriptan. So know about triptans and their mechanism of action. Basically, they all do the same thing. It just some people respond slightly better to one than another. Anybody know the symptoms of a pediatric migraine? So pediatric migraines typically are GI related. Yeah, so they often get misdiagnosed. Interestingly. So you should have relief within 2 hours. Comes in all these forms. You can take a pill, you can take a sublingual. Some people can't get it down, right? If you've got nausea, the last thing you want to do is swallow a pill. So we've got sublingual tablets, we've got nasal sprays, we've got subcutaneous injections, any way to get it into your body to break that headache. That's an injection. So adverse effects are related to the mechanism of action. What was the mechanism of action? Vasoconstriction. So I'm giving you a hug. Vasoconstriction is the mechanism of action of the triptans. So all of the adverse effects typically are going to be related to vasoconstriction, other than if it's an injection. So there is a contraindication in any sort of vascular condition where you already have a narrowed pathway. So if you have coronary artery disease, you have a narrowed coronary artery. The last thing you want to do is vasoconstrict that and cause angina and cause a heart attack. Same thing with a stroke. If somebody had an ischemic stroke where the cerebral vessels are quite atherosclerotic and narrow, the last thing you want to do is vasoconstrict them. So these medicines are contraindicated in these diseases, and so you need to you'll maybe recognize in a question somebody saying something about, your patient has this particular type of history, and maybe you're anticipating a medicine being prescribed and triptan is one of the options. You would know if they have any sort of vascular condition where their blood vessels are narrowed, that we will never give it. It's also a category C in pregnancy. So this was the older treatment for migraines, this ergot alkaloid, ergotamine. It's an old herbal, indigenous treatment. Also comes in combination drugs. Again, they are, excuse me, especially they put it with caffeine to get extra bang for the buck for the vasoconstriction, because that's why caffeine gets rid of a headache, because it's a vasoconstrictor. That's why your blood pressure goes up when you, for some people, when you drink caffeine, because you're vasoconstricting. All right, so exact mechanism is not known. Same idea to vasoconstrict. Adverse effects. Again, same contraindications. Don't give it in coronary or peripheral vascular disease. And then we have some precautions if people have diabetes or they're old. Or if they're a tobacco smoker, we expect that their vasculature is pretty crappy. So ergotamine alkaloids and triptans. So why are we monitoring for chest pain if somebody's taking one of those drugs? So because of the vasoconstriction, right, on their potentially on their coronary arteries. These are all symptoms of vascular ischemia in the brain, stroke-like symptoms. This is a crisis, immediate medical attention. This is the newest on the market, this calcitonin gene-related peptide inhibitor, and it is a prophylactic. It's prophylactic and preventative, or prophylactic and acute abortive. Thank you. It's both, one by injection and one orally. This is the one I've seen when I was at the VA for people who were not well managed by any of the other treatments, or they weren't eligible for them. A lot of the older adult population already has coronary or cerebral vascular conditions, and so they can't take an ergot alkaloid, they can't take a triptan. So we move on to this class of drugs. I love the name Rogitant. Awesome. This is the first class of migraine-specific meds that is not vasoconstrictive. So you can see why people who have vascular disease would, this would be the drug of choice. It is actually a vasodilator. CGRP is a vasodilator. So if we interfere with that, with the mechanism of action for that neuropeptide, if we block it, we're not going to get vasodilation. So the other ones, you're already vasodilated and we cause vasoconstriction. This one is dealing with the mechanism of action that causes the vasodilation. So if we block it at start, we can block the vasodilation, thus block the migraine headache. Kind of a note. Half-life is 1 month. So how long does it take to get out of your system? 4 to 5 months. Yeah, long acting. And I think if you have migraines, you probably appreciate that. We don't have enough studies because remember, there are no clinical studies on people in pregnancy. We just wait to see what happens down the road and then we decide. And so we just for now say, don't take it in pregnancy. Let's see. And then Botox. This one is better for the muscle related issues. So a lot of people have occipital headaches, occipital migraines, so at the back of their head, going into their neck. So Botox gets used, obviously, for the same purpose as it's used cosmetically to paralyze the muscles. So if you paralyze the muscles, you won't have that muscle constriction that's causing this muscular type headache. There's a black box warning that if you get it into the bloodstream, you can paralyze the muscles of breathing. So yeah, it's the same risk as getting it cosmetically. Let's see, what is important for the nurse to assess in the patient's history before administering a serotonin receptor agonist, which is a triptan? Which one of those are the key? The triptans. What's the mechanism of action for triptans? Vasoconstriction, so you would be concerned about hypertension. You don't want to vasoconstrict somebody whose blood pressure is already high. And then the one that we they do review, is this for neonatal apnea? So obviously, neonates born prematurely often lack the respiratory drive and the lung capacity. So basically, we're just stimulating these newborns, stimulating their drive to breathe. Yeah, give them, babies coming out drinking coffee. Mom. All right, so they stimulate the areas of the brain. So 70% of premature infants have neonatal apnea. So just recognize that particular use for it. And then all of the over-the-counter products that we have, I just chose no dose, but if you go into the grocery store, you'll find an entire section, and they all are going to contain caffeine. These are the prescription drugs that contain caffeine. We know about foods and beverages. So caffeine is everywhere. That's the which is the one that so, apnea. Oh yeah, so doxapram is for respiratory depression associated with anesthetic or anything that's suppressing the drive to breathe. So you can see all of these, the thing that they have in common is inhibition of the drive to breathe. This is from hypercapnia or CO2 trapping within the lungs because of decreased lung capacity. You can't get the CO2 out when you exhale, so you get CO2 buildup, and it suppresses your drive to breathe, which is why we don't give high doses of oxygen to people with COPD, because it increases their CO2 trapping and decreases their drive to breathe. So that's just a little caveat, because my husband would want me to say that he's a respiratory therapist. Nothing pisses him off more than coming in that the nurse cranked the oxygen up on a COPD patient because he was like 92. That's a wonderful oxygen stat. Anyway, adverse effects all come from stimulation. These are all vagal, vasomotor, respiratory, that's the desired effect, musculoskeletal, they're all stimulants. So it's nice to kind of think about these drugs. They're all in the stimulant class. We had ADHD, we had narcolepsy, we have weight loss, we have the drugs for respiratory suppression. I mean, all these things fell within this class. And then they would add some other ones on that weren't stimulants. Like we had the anorexians, stimulant anorexians like phentermine that was for weight loss. And then they talk about orlistat, which interferes with the GI absorption of fat. And they talk about the triptans and the ergot alkaloids, which are stimulants and cause vasoconstriction. And then they talk about the CGRP inhibitors, which are a different mechanism of action. So if you can just kind of remember all that chapter in that way, it helps kind of categorize at least the beginnings of where these drugs fall. All right, that's 13. Everybody knows all that stuff, right? Right, that's what you say, right. Let's look at 14. Any questions about the stimulants? So we did CNS depressants and CNS stimulants. Right. You need to really study them, kind of get them into your mind. Okay, the way I study is I would do CNS stimulants and then all of the things that could be treated, the conditions, and then what are the drugs to treat those conditions, and then what are the mechanisms of action. That's how I think. But you do you. All right, so epilepsy, super common condition, electrical misfiring. You know, it's kind of like when your computer's on the fridge. This is the most common neurological illness, so that you should be familiar with the medicines that are used to suppress the overactive electronic firing. All right, so the following terms, they're used interchangeably, but they don't have the same meaning. So a seizure is a brief episode. A convulsion is when there are involuntary muscle spasms. And epilepsy is the disease or the syndrome of chronic recurrent seizures. So there's a difference between a seizure, a convulsion, and epilepsy. We use them interchangeably, but there is a difference. So if someone is speaking, you need to make sure you're clear on what they're talking about. Most of the case, well, at least half the cases, we can't figure out why it happened. There wasn't trauma, there wasn't, there was nothing. It just happened. The rest of them we can identify. Either they had a brain injury or they had an infection that traveled into the brain, meningitis or something, or they have some, mets to the brain, or they had a stroke. Anything that disrupts the structure of the brain can cause seizures. We know that some young children develop febrile seizures. This is a genetically linked condition, and it comes related to rapid rise in fever. It is very uncommon. Most parents are super over hyper vigilant, but it's very rare. And then in alcohol withdrawal, we know that people tend to go into seizures just because of the withdrawal of the central nervous system depressant. So you can imagine if you're suppressing a neuron firing in the brain with alcohol, and then you suddenly withdraw it, you get this rebound firing, which is what's going to cause these seizures. So you can kind of understand why it happens. These are just different types. Don't really feel like you need to know the difference between grand mal seizure and a tonic or tonic-clonic, but just recognizing that what tonic means, what clonic means, and then an absent seizure. I've actually seen that before, where somebody just looks like they're staring off into space, just totally gone, and they're having absent seizures, where they don't have the characteristic jerky seizing type activities we think of. So someone can have a seizure and not have the classic, what we think of as seizures. Their brain is still firing. So what status epilepticus then? It's that uninterrupted firing where you are having brain firing and having seizures nonstop. There is no end. Okay, that can't be good for you. It's like your finger in the light socket. You don't want to keep it in there too long. It's not very good for you. So there's no recovery between seizures. You are messing with all of the wiring for breathing and for your heart to beat. This is where it all comes from, right? So if everything's on the fritz there, it's a medical emergency. We need to interrupt that seizure so we can get normal firing to stay alive. All right, so are there cures for seizures? Have you ever?
Medication.
Okay, there's no cure. We can't we can't solve it.
Manage it.
Right. So the goal of therapy is to manage the symptoms and minimize the side effects. This is something you should know. They like to test on it. What are the goals of therapy, or what are you going to teach a patient? You're going to teach them this is a lifelong, typically a lifelong condition. Some people have seizures once and then never have them again. It was related to an acute event, but typically people who have recurrent seizures will need to be on lifetime therapy. Our goal is just to figure out what quality of life they would like to maintain, because the side effects can be significant. And that's a statistic, 40% never occur again. So some people go on it for 3 months, and then the neurologist will take them on a therapeutic trial off if they're willing, just to see if there's no obvious.
TJ's been on seizure medicine his whole life, and he doesn't have frequent seizures. It will be like breakthrough, like maybe one a year, if that. Because of that, he's doing so different seizures now. Would you like dwindle the medication down and instead of going cold turkey.
Well, so what's keeping him from having seizures? It's the medicine.
Exactly, and I don't want to
So-
mess with it, but at the same time, it doesn't need to be on it. But
If he's still having a seizure and he's still having breakthrough seizures, then he still most likely needs medicine. Because I imagine if you withdrew what's keeping that under control, you would have a flare again. I mean, that's just random thinking, not knowing anything about it. So generally we start low and go slow as much as possible. You start with a single drug, you go up, and then we may add another drug. Certain anti-epilepsy drugs, we have to monitor their drug therapy because they have a narrow therapeutic window. There are some that are not monitored. Levetiracetam and lamotrigine are not monitored. And so anytime we're talking about labs that you therapeutic drug monitoring, so you will need to know what are those lab values. So this is just an overview of the classes. Here, what do we see again? We saw it before in central nervous system. What? Stimulants or depressants?
Barbiturates? Is it depressant?
Depressants, yes, because you would want to calm down that neuron activity. Hydantowins and immunostilbenes. I had to look up, I never heard anyone say that before. I just usually say the drugs. Valproic acid, super common. And then we have some other drugs that get added on. Oftentimes we don't know how it works. That's really great, isn't it? That we just give you a drug. We're not really sure how it works, but it's sort of like antidepressants and anti-anxiety meds. We can't test neurotransmitters in the brain and know, okay, and measure, oh, we gave this much and now we have this much. So it's trial and error. Usually we think we're just messing with the flow of ions for neurotransmission. So if we're messing with ions, probably those are going to be the things that we have to keep an eye on. Sodium, calcium, potassium, magnesium.
What's the
Mechanism of action. Sorry. Unapproved abbreviation. -5 points for me. So this is where I put GABA. Oh, I knew it was somewhere. So we were talking about in the depressants about the role of GABA, gamma aminobutyric acid. And nobody will ever ask you to say that. It's just always GABA. It's the primary neuroinhibitory neurotransmitter. So we have neurotransmitters that stimulate, and then of course we have a great system where we have neurotransmitters that inhibit. So this is the kind of the balance from stimulation to inhibition. Otherwise you'd be stimulated all the time. So we can do lots of things with GABA. We can tell our body to make more GABA. We can tell the body to keep the GABA in place for longer. Yeah, we'll talk about a few of them. So one of the functions is to kind of block excitatory areas, reduce the nerve's ability to be stimulated, or block the transmission, or decrease the speed. All of those are kind of inhibitory actions. So it doesn't get started, or if it does get started, we make it go slow, or if it does go slow, we try and prevent it from traveling to the next neuron, just to think of it in layman's terms. So this is just other stuff, because we'll come back to it quite frequently. Altered GABA signaling happens in other diseases. We think that it plays a role in ADHD, altered GABA signaling. Anyway, so then we have acute treatment. So anybody who's having an acute episode that needs to be broken, we have acute treatment, and then of course we have the long-term maintenance, and we have add-on drugs that we use. And there are other classes of drugs that either we found out they work for seizures, or they initially work for seizures and we use them for other stuff. So there's nerve pain medicines and psychiatric medicines and migraine medicines. So why do we like to add on adjunct medicines rather than just give a high dose of dilantin? What's the thinking behind adding a second drug or a third drug? Rather than increasing the dose of the first?
If you could lower the doses of them, then you could avoid some of the side effects.
Exactly, that's the point. That's the point in, remember balanced anesthesia, when we talked about that term, was they took a little bit of this and a little bit of this and a little bit of this in order to achieve anesthesia without having a lot of side effects from a high dose. Same thing happens with seizures. We often give a little bit of this and a little bit of that. That just means more pills for people to take, unfortunately, but it does reduce side effects. We also use it as prophylaxis for people with head injuries or people undergoing brain surgery. So why would you give an anti-epileptic to someone who had a head injury or someone who's undergoing brain surgery? Yeah, so exactly. We've now had a structural change in the brain. So the potential for abnormal neural firing is high. And we know that there's going to be intentional disruption in the structure of the brain with brain surgery, right? We know we're going to interrupt the firing. And the last thing we want is the patient on the operating table who's undergoing brain surgery to start having a seizure because we're disrupting brain signaling. Makes sense. Let's see, adverse effects. We're going to go over some of them. Sometimes they're intolerable. Dose gets lowered, still intolerable, change bed. You need to know that all anti-epileptics in general have a black box warning as of 2008 for increased risk of suicidal thoughts and behaviors. Lots of drug interactions. So some of them induce hepatic metabolism. So what was that term called when a drug induced metabolism? Induction. So what happens when we induce metabolism? So you take an anti-epileptic drug and it induces metabolism of the other drugs. What do we need to know needs to happen with the other drugs?
They need to increase.
They need to be increased because the drug we're taking sped up their metabolism and they're out of your system sooner. It's unfortunate. Women have the great fortune of having a lot of these interfere with birth control. So really important with patients of reproductive age to be talking about reproduction, talking about, intentions not to or not have children. And then just in general, the motto is avoid grapefruit at all costs.
And pomegranates?
Yeah, some of them have a pomegranate. Carbamazepine has an interaction with pomegranate. It's the CYP 450 metabolic, the pathway they follow they're competitive for. So there are some critical adverse effects. Stevens-Johnson syndrome and toxic epidermal necrolysis, which is known by its initials TENS, toxic epidermal necrolysis syndrome, is associated with all of these seizure medications. What kind of medicine is phenobarbital? We've talked about it. Barbital, barbiturate, right? Perfect, barbiturate. So we've already talked about that class of medicine. So now we know that phenobarbital has a risk of toxic epidermal necrolysis or Stevens-Johnson syndrome. And so they are both skin syndromes where there's sloughing of sheets of skin, kind of like a burn victim. You've lost your protective layer. You're at risk for infection and dehydration and kind of a serious event. This is toxic epidermal necrolysis, where his skin is just sheeting off. That is a critical drug reaction. So knowing that can happen with some of these seizure medications. So phenobarbital and primidone. So primidone gets metabolized to phenobarbital, just like, let's see, what was another drug we talked about? That got metabolized to another drug. It'll come to me. I was gonna say acyclovir, but we haven't talked about those. So anyway, they're both active drugs. Both the drug that you take and its derivative, its metabolite, are both active. Yep, contraindicated in pregnancy, major malformations. And because it's a CNS depressant, remember barbiturates fall under CNS depressant category. So all those are the potential adverse effects that we talked about before. Here's the therapeutic level. For phenobarbital, you should know 10 to 40 micrograms per milliliter. You will need to review the contraindications on your own. We already did that. Most common adverse effect is sedation. Hydantoins, the class is hydantoin, the most common one out there, and kind of super common, super old drug. It's a good drug, but it's kind of hard to manage. Phenytoin, was the first line drug for a really long time. There's the therapeutic levels. It's pretty narrow, 10 to 20 micrograms per milliliter. So one of the problems with phenytoin is it's highly protein bound. So remember when we talked about protein binding and some of the complications that can happen if a drug is highly protein bound? So who can remember what's an issue with a drug that's highly protein bound? I mean, it is. So which is the active drug? The drug that's protein bound or the drug that's not protein bound? Right. The active drug is the unbound drug. When it binds with protein, it is now inactive. So the active drug is the unbound. So it's really highly protein bound. So it's dosed in order to release. So you've got this dose here, and they all bind up with protein and protein. And this is the free drug. And the free drug is the active drug. They're highly protein bound. So what happens if you are taking multiple drugs that are highly protein bound? You have a limited amount of protein, right? You don't just suddenly get more protein because you're taking another highly bound protein drug. Yeah, you get some bumping off depending which has the stronger affinity. So if I start taking warfarin, which is highly protein bound, and now I've got this, well, now I've got extra phenytoin floating around. More free drug. And it's hard to predict which is going to, how much it's going to be pushed off of the protein binding sites, how much extra free drug you're going to have. So if you have a bunch of protein, highly protein bound, you end up with all this free drug because there's no more sites to bind to. It was bound to warfarin because warfarin was even more selective. And so now we've got all of this dioantin, this phenytoin floating around. You could be super therapeutic. Now you're subject to all the adverse effects of being outside the therapeutic drug level. And it's simply because of competition for the protein binding sites. And that's the mechanism of action for the interaction with warfarin. It's all about protein binding sites. So warfarin is what type of drug? Anticoagulant. So can you imagine you have a seizure drug and an anticoagulant competing both for the same protein binding sites? You will have erratic blood levels of both substances. Right, it's hard to control because they're competing for the limited amount of protein sites. What if you are a malnourished? You know, we have a lot of obese, malnourished people. Just because somebody has a lot of body fat doesn't mean they're eating a lot of protein. What are they having? Hot Cheetos with ranch dressing for lunch. You know, a lot of carb food intake and very little protein intake. So now they're going to have this unexpected high level of free drug because there aren't enough protein binding sites. People are malnourished. All right, so what do we watch for? This is the picture of gingival hyperplasia. And it's the classic question they like to ask you, one of them about Dilantin. I mean, long-term use can cause this overgrowth of your gum tissue. So basically, you're supposed to be teaching patients to take, immaculate care of their teeth and gums and to see their dentist regularly. This is acne is one of them, hirsutism. Hirsutism is typically affects women where we get abnormal hair growth in places where women don't want it, so facial hair. This is a picture of it, of a woman who's got facial hair. That could be really significantly impacting their quality of life. Now you can see why an adverse effect would be intolerable. A woman is, is impacted by facial hair growth. It may not be acceptable to take this drug. And for somebody else, a man, they're like, great, look at me, I'm growing a full hardy beard. And it's just fine. And then this term called Dilantin facies, which is just a loss of the hard features of the face. You start to have like a less defined features like children do. It's really, babies and children don't have well-defined facial features. And the term is Dilantin facies. So they like to ask about gingival hyperplasia and Dilantin or facies for some reason when those are not the most important things. But you should teach patient about it. Dilantin phenytoin is also associated with this measles type rash. So you can expect that that's something that would show up in a question. A patient, shows up with they will say a measles-like rash. And you're reviewing their meds, and one of them will, a med list, and one of them will be phenytoin. They're expect you to recognize that's a potential adverse effect of the phenytoin. Lots of things to know about the administration. It's kind of a caustic substance. It's really harsh, so we need to have it in a large bore IV, and it needs to go real slowly. And it has to have a filter. This is a picture, it's not a good one because I blew it up, but the IV infiltrated. So everybody knows what IV infiltration is. The fluid leaks, it's no longer in the blood vessel when you place the IV. It's now leaking out into the tissues. So that's infiltration. And so this was infiltration of phenytoin into the hand from the nurse wasn't monitoring close enough to see that this was starting to infiltrate. So we got this purple glove syndrome. Tons and tons of IV incompatibilities. If a patient's taking phenytoin, you're going to look up any drug that they're going to take just to make sure. So those are the key things about administration. Large bore, go slow, drug incompatibilities, therapeutic levels, Dilantin facies, gingival hyperplasia. All right, the aminostilbenes, like I say, we don't say that. There's carbamazepine and oxcarbamazepine. Carbamazepine came first. It's Tegretol. And it does have a window that can be monitored. I never drew any labs on this, but there is a therapeutic window that they mentioned, so I suggest knowing the therapeutic window. Again, women, it reduces the effectiveness of birth control, lots of drug interactions, especially warfarin. A lot of these drugs have liver toxicity. So watching for the labs that we are watching for liver is the liver function tests. And then also we are watching the CBC typically. If somebody's being started on it or a dose is changing. And we know it can depress, this is why we draw the CBC, because we know it can depress platelet production. So if you have low platelets, you're at higher risk of bleeding or not being able to stop bleeding. Tegretol. All right, okay, this is one, this is a pretty significant interaction. carbamazepine with warfarin. So oftentimes if someone's on warfarin and we want to use one of these drugs, we'll switch them to oxcarbazepine. It's very similar, but it doesn't have that drug interaction. It does have the birth control problem, the hepatotoxicity, and risk for low sodium. So remember in the beginning, we said oftentimes we don't know the mechanism of action, but we think we are playing with ion flow and sodium, potassium, magnesium. So this is one that is known to drop sodium. All right. Oh, here's a fun one. A patient in a long-term care facility has a new order for carbamazepine for seizure management. The nurse is correct when recognizing autoinduction as which response? Autoinduction. Toxic levels of carbamazepine. This is a really bad question. Lower than expected drug levels. Gingival hyperplasia, cessation of seizure activity. Do you remember we talked about autoinduction? Yeah, where the drug induces its own metabolism. Yeah. So the drug itself stimulates the metabolism of the drug. Awesome. So we get lower than expected drug levels. That's one of the phenomenon with carbamazepine. No carbamazepine, warfarin interactions, autoinduction. Those are kind of those are the kind of the key concepts for that group of medicine. This is the miscellaneous gabapentin. What have you seen gabapentin, or what do you know gabapentin gets used for?
Supposed to be for nerve pain.
Nerve pain, right? It originally was a seizure medicine before it became a nerve pain, but you could see how that would happen if we're interrupting nerve activity for seizures. It could interrupt nerve activity for pain. It kind of makes sense. So we think there's the root of the word GABA, right? Gabapentin. So we think we're playing with GABA. We're either making the body produce more, or that we're keeping it in the synaptic cleft longer. So this is the synaptic cleft over here, where the neurotransmitter is released. And if we can keep it in here and not have it broken down quickly, then we have more inhibitory activity. GABA is inhibitory. Just remember that one. Not a lot of contraindications. And the thing we like is because there's no hepatic metabolism. Well, virtually none. This one's actually metabolized by the kidneys. So remember we said most drugs are metabolized in the liver, but that doesn't mean all. So no significant drug-drug interaction. So this is why this is a great seizure drug, because there's not a lot of contraindications. It isn't cleared by the liver, not a lot of drug-drug interactions. Pretty awesome medicine. However, it is currently a drug of abuse. It's not scheduled, but it's in the process of becoming a scheduled drug, where you would have to have a controlled substance license to prescribe it, just like oxycodone or Adderall, the stimulants. Pregabalin is the derivative of gabapentin. Basically, gabapentin is the active prodrug, and pregabalin is the metabolite that's also active. I always told patients this is like concentrated. This is how I told the patients. It's like concentrated gabapentin. It's pure, because it's gone through the first step of metabolism. That's how I teach it. This is a controlled substance already. So, because it's a drug of abuse, people abuse it. People abuse everything if it gives any kind of euphoria. So seizures, but more commonly neuropathic pain. People who have herpes zoster, or which is shingles, who have pain after the shingles has gone away along the nerve fibers. We can use pregabalin for that. And then this fibromyalgia, this kind of nebulous condition that we recognize, can have an inflammatory component to the nervous system. So those are the main uses for it. We're not using pregabalin necessarily for seizures. They throw it in here because we talked about gabapentin for seizures. So don't get confused. Lamotrigine is out there. That's another. This is a medicine we use in the psychiatric world. It gets used for bipolar disorder. And for some, so we use it for some seizures. So we might have a little bit of phenytoin, and we might add a little bit of gabapentin, and we might add a little bit of lamotrigine in order to control people's seizures and not have those high side effects. Again, the risk of Stevens-Johnson is there. Let's see, contraceptive interaction. Women get cursed with everything. This is one that we don't draw labs on. It's just kind of out there. The last one is the levetiracetam Keppra, which is an old drug, super common as well. We don't know how it works. That's great. You don't have to learn the mechanism of action. We don't know how it works. These are the therapeutic drug levels. There's no clinically significant drug interactions. We like this drug for seizures. Topiramate. Yeah, topiramate gets used. So when we were talking about phentermine, which is a stimulant anorexian, meaning central nervous system stimulant used to suppress appetite, and we had talked about phentermine. Sometimes we add, there's a drug that on the market that's phentermine with topiramate, and it's used for the adverse effect of appetite suppression. So this is a seizure drug that's getting used in other purposes like appetite suppression. We also use it in pain control as an adjunct pain agent. We don't know how it works. Same issues with interactions with oral contraceptives. This is one they, for some reason, like to talk about the angle closure glaucoma. That's closed angle glaucoma as opposed to open angle glaucoma. And then there is a risk of cleft palate for babies during pregnancy. So that would be a benefits risk question. If there was nothing else mom could take, cleft palate, we try and avoid it. Topiramate. All right. Valproic acid. It's a lot of drugs, right? And I can see your head's like swimming. Valproic acid, again, highly protein bound. So now we know all the implications of a highly protein bound drug. Interacting with other highly protein bound drugs. Narrow therapeutic window here, that's one you should know. It is another one that has the risk of hepatotoxicity, liver damage. This derivative, most people know Depakote better, because usually we're giving Depakote because it's long acting, where valproic acid is multiple times a day. So they came up with a longer acting form of it, which is divalproic. So this is valproic, this is divalproic. Short acting, long acting.
I'm sorry, can you go back to that?
Yeah.
That is short acting.
Valproic acid, you need to take it multiple times a day, either 3 or 4 times a day. And Depakote, I believe, is once or twice a day. It's been a long time since I prescribed it. So yeah, this is obviously people don't want to take things multiple times a day. But so that's just knowing they are basically the same drug. So they have the same protein binding, the same precautions, the same clinical adverse effects. All right, we already know this one. This is just patients on Neurontin, but he says he doesn't have any problems with seizures. We know that he could be taking this for pain. Yeah, it's just kind of one of those general. Well, let's take a break, you guys, just because it's 2:30 and you've been here for 2 hours now. Stretch your legs. Have more cake. I'd do it. Yeah, anti-seizure medicines, yeah. So some of the drugs we didn't talk about, diazepam, barbital. So what is diazepam? What category of drug is diazepam? I just have this Quizlet up. This is talking about seizures, it's talking about phenytoin, a drug we didn't talk about, and also diazepam. What class of drug is diazepam? benzodiazepine, right? So here it is coming up again. We learned it under CNS depressants, but it comes up again as a seizure medicine, again, because it's a central nervous system depressant. So, yeah, find all of those fun things to go over. I think they're fun. Let's see. What is chapter 15? I bet it's Parkinson's. Parkinson's is a fun one. Well, not for the patient with Parkinson's. Did I post any of these? No? Knucklehead. So Parkinson's, let's talk about Parkinson's. Man, you guys are getting hit with lots of classes of drugs. So what do we know about Parkinson's? Bet this is still moving.
Did you already publish the PowerPoint?
I thought I did.
Parkinson's disease is considered a neurodegenerative disease because it involves the degeneration and death of neurons. It is most frequently seen in adults over the age of 50. The most recognizable symptoms of Parkinson's initially are movement related and generally involve a tremor that is worse when a person is at rest, bradykinesia, which is slowness of movement, rigidity, and postural impairment. Parkinson's patients also often experience non-motor symptoms like cognitive impairment or psychiatric symptoms. The causes of Parkinson's are not fully understood, but a combination of genetic and environmental factors is likely involved. Parkinson's patients have low levels of the neurotransmitter dopamine in the basal ganglia, a group of structures involved with movement, among other functions. These low dopamine levels in the basal ganglia are caused by the death of dopamine neurons in a region of the basal ganglia called the substantia nigra. The substantia nigra has high numbers of dopamine neurons. By the end stages of Parkinson's, patients have often lost more than half of the dopamine neurons in this region. The most common treatment for Parkinson's involves an attempt to restore depleted dopamine levels in the basal ganglia. Because dopamine does not cross the blood-brain barrier, dopamine cannot simply be administered to a patient. Instead, however, patients can be given a precursor to dopamine called L-DOPA. L-DOPA can cross the blood-brain barrier and is used by the brain to synthesize more dopamine. This can lead to improvement in the motor symptoms of Parkinson's, but L-DOPA does not halt the neurodegeneration that occurs in Parkinson's disease. And long-term use of L-DOPA can cause a number of side effects, including movement-related problems. So it's not a cure for the disease, and other treatments are still being explored.
So that's basically Parkinson's in a nutshell. Lack of dopamine causes the Parkinson's symptoms. So you should know what the classic Parkinson's symptoms are: tremors at rest, bradykinesia, postural instability. They kind of went over them. So we are trying to restore dopamine levels in the brain for as long as possible. Again, there is no cure. So what would our treatment goals be if there's no cure? Right, control and minimize side effects. Same thing as for seizures. We are trying to, unfortunately, Parkinson's is progressive, and we don't have any way to delay the progression of the disease. It's not, we just don't have that knowledge yet. So that's really hard news to tell someone. Age-related? It's just that we see it more in adults older than 50, but it can happen younger. I mean, there's Michael J. Fox was an actor in the 90s who got it at a young age. It's less common, but it's not caused by age. It's just associated. There's an association. And then there are all these non-neuromuscular symptoms that we forget about. There's Parkinson's related dementia and Parkinson's depression and Parkinson's psychosis. And that's all related to lack of dopamine in the brain. So what do we do? The treatment is to delay it. Okay, let's start at the beginning. So treatment is, we'll start with the nurse. So you or the doctor may be the one to explain it. We're going to start drug therapy. Oftentimes you'll need, as your symptoms progress, you may need other adjunct therapies. There is good evidence in some patients for deep brain stimulation in Parkinson's, but imagine the risks that come with doing brain surgery. So it's lots of risk benefit analysis, and I've never known anyone who underwent deep brain stimulation.
So I work at neurosurgery.
Oh, do you? Oh, yeah.
Patients love it.
Yeah. Is it, what's the age range of patients that are,
Mostly,
yeah, I mean, 60, I would say, I would do it if I was 60. I don't know if a surgeon would want to do it if I was 80. I don't know.
in some cases.
So
but
if
it's
you're
not-
a young 80 and you've seen good outcomes, awesome. Thank you. That's interesting to share. And I may just not see it because of where I've worked, not having been in a neuro unit. So we have two pathways to address this dopamine deficit. We can give a drug to replace dopamine, or I love this term, a non-dopamine dopamine receptor agonist. That's a mouthful. So it's telling you it is not dopamine, where these are dopamine replacements. So the drug is not dopamine, but it is acting at the dopamine receptors as an agonist to stimulate dopamine activity. So two different mechanisms of action. We're working on, all of them work on either the presynaptic or postsynaptic neurons in the brain. But our focus is either replacing dopamine or playing with the receptors for dopamine. Anybody know this movie with Robin Williams called Awakenings? Yeah, the older people know it because it was a 90s movie.
It was so good.
Yeah, really good, about a guy who worked in a unit where everybody was catatonic. And he had a theory that their catatonia was, he theorized it was Parkinson's to the extreme, that they had symptoms to the point where their tremors were now so fast that you couldn't see them. They were just tremoring and catatonic. That was his kind of working theory. So he tried L-DOPA, and in this movie based on a real life story, patients had their dopamine restored to their brain and they began to function as a human being again. Really a cool movie.
Then you like throw a ball and someone that was catatonic, but like.
Yeah.
And you grab the ball, you're like, what just happened?
Yeah. Now the problem with L-DOPA, levodopa, you have to have working nerve terminals in order to produce dopamine. So remember they said that L-DOPA is the precursor to dopamine. It has to cross the blood-brain barrier and be converted into dopamine. Well, you have to have a functional system. So when you get in the late stages of Parkinson's where things continue to degenerate, levodopa stops working. And that's the sad thing. So we often try and delay starting levodopa so we can get the maximum amount of time, and yet we need to give it early in the disease. It's quite the balancing act. Let's see. So large doses of levodopa, if we were giving it by itself, we would need to give patients large doses in order to cross the blood-brain barrier. So what we did was combine it with another med called levodopa, or carbidopa, sorry. So we combined levodopa with carbidopa. This is the common brand name you'll see there. So you'll see two numbers, like a 25/100 in the dosing. One is carbidopa, one is levodopa. So carbidopa doesn't cross the blood-brain barrier, but it does ensure that this levodopa doesn't get metabolized before it crosses the blood-brain barrier. So it's keeping it around longer. And then, yeah, it allows lower doses of levodopa to be used. So basically, it's like a helper. You would need a high dose without it. You can use a lower dose with the helper. And that way you have less side effects. Often nausea and vomiting are the worst side effects of these meds. So carbidopa, levodopa. Carbidopa doesn't cross the blood-brain barrier. Levodopa is the drug that becomes activated. So I like this one because it talks about what happens. So here's levodopa, and it's in the bloodstream. Here's carbidopa. Its job is to make sure that this doesn't get metabolized until it can get into the brain. And it also prevents the action on peripheral, but we'll just talk about this. So in the brain, we now have dopamine, and dopamine is broken down by monoamine oxidase, which is an enzyme, and COMT, long terms. So you can already see, all right, here is the dopamine replacement, the L-dopa. Here are the we can play with these mechanisms to come up with a non-dopamine drug. If we can prevent these enzymes from working, enzymes break down drugs. If we can prevent them from working, they won't break down dopamine, and the dopamine will stay in the system longer. So that's pretty clever. So we have direct dopamine replacement drugs and non-dopamine NDDRA. Yeah, nice. So there is a phenomenon with people who take Parkinson's medications called on-off phenomenon. So you should be familiar with that. Nurses explaining it to a patient. Which of these describes what an on-off phenomenon is? Yeah, it's the periods of good control and periods of poor control. So periods where the drug is not exerting its therapeutic effect anymore. So you have a waxing and waning of symptoms. So this can happen when people take it on a long-term basis. And it's annoying. And so neurologists typically try and up the drug or change the formulation. We do have some longer acting formulations so that they can not have these on-off symptoms. All right. So, yeah, so when the dopamine levels drop, they have the opposite symptoms. So this is interesting that dyskinesias or movement-related abnormalities are a side effect of getting too much dopamine. So you have movement abnormalities from a lack of dopamine, bradykinesia, akinesia, and then you have movement-related abnormalities from too much dopamine. So how do you know which it is? You should know that that's a potential adverse effect of taking any drug that plays around with dopamine. So you should know some of these terms: akinesia, dyskinesia, bradykinesia.
The dyskinesia is difficulty.
Yeah, it's just a general term of the broad umbrella. Like dementia is a general term, and then we can say what are all the types? Well, there's Alzheimer's dementia, Lewy body dementia, alcohol, vascular dementia, Parkinson's dementia. Right? It's an umbrella term. So this was the controlled release. They came up with a longer acting formulation to address the fluctuation of the dopamine levels in the brain, where the enzymes have broken down the dopamine. Now your dopamine levels drop, you have the off episode. So they came up with a controlled release so that it's released more slowly. That way you don't have as much off time. So here's one that's best taken on an empty stomach. Seizure medications, best taken with food. Carbidopa, levodopa, best taken on an empty stomach. Sometimes it's hard for patients because they get nausea taking it on an empty stomach. So there are some drugs that the instructions are it's best to do it But we also throw the caveat in, if you can't tolerate it because you become nauseous and vomit, it's okay to take it with food. Generally speaking, the prescriber will adjust the dose to compensate. There is competition with protein. So I saw this on one of the questions one term about what do you need to teach the patient? And one of them was about because of the interaction of the drug with protein, you want to make sure that you're taking it 30 minutes before a meal that's high in protein. That kind of corresponds with best taken on the empty stomach.
I'm sorry, how does that correspond with taking it on an empty stomach? Oh,
30 minutes before a meal would be your
Okay.
empty stomach,
Before.
theoretically, unless we're eating when we don't have an empty stomach. So the contraindication, you may see glaucoma show up. This is the interaction with protein. It just reduces the effectiveness of the drug when taken with a high protein meal. And interact if somebody's taking dietary supplements like vitamin B6, people take random and sundry things. So dyskinesias, the adverse effects of a therapy for a dyskinesia, it can be a dyskinesia. The GI distress, these are the common ones: nausea, vomiting, anorexia, and then of course dry mouth, diarrhea, constipation. They're all GI symptoms typically. Some people can develop ulcers, GI ulcers, which is unfortunate because we're telling them to take it on an empty stomach. Not so nice. So this is kind of the stages of Parkinson's. You can see people that just have the tremors at rest. It can be just one-sided, can be really mild, and as it progresses, this is kind of a postural instability where they've lost the muscle tone in order to stand upright. You'll see them stooped over, and eventually they'll be wheelchair bound. The time from the lifespan of levodopa is about 5 to 10 years. So if you get Parkinson's at 55, we know that basically the levodopa drug has a life of 5 to 10 years before it no longer works for you, because your dopamine production or receptors will have been damaged. And that's why they try and delay, like, to give you more time later on. But that's really the bad news, is that, okay, with a seizure medication, you can take the seizure med for the rest of your life. This one loses its effectiveness.
What's the HY?
I have no idea. I just found this one because I like the progression of the symptoms, HY, early stage HY. I don't know. It's high. So this is the non-dopamine dopamine receptor antagonist, sorry, non-dopamine dopamine receptor antagonist.
I thought it was agonist.
Non-dopamine dopamine receptor.
Should be an agonist because it's going to affect the.
Receptor agonist. Yeah, non-dopamine dopamine receptor agonist. Okay. So we saw ergotamine with migraine headaches. I know that you guys have a lot of interesting things to talk about. This one, so if we talk about synapses, right? When you have neuromuscular synapses, that's the activating, like that's the N terminal. So you have a neurotransmitter here and a neurotransmitter here. This is presynaptic, this is postsynaptic. So it activates presynaptic dopamine receptors to stimulate the production of more dopamine. So we are asking the body to use its resources to produce more. Yeah, so it's not directly providing dopamine. We're telling the body, you know, give me more dopamine. So it's an adjunct therapy so that we can lower the doses of levodopa so that people have less GI upset, risk for hypotension, risk for cardiac dysrhythmias, lots of risks with the higher the dose.
So question, If it is structured in this manner where they are taking lower doses of levodopa, does it still have the effective lifespan of 5 to 10
Yeah, it
years?
doesn't change the lifespan, it doesn't change the course of the disease.
So whether you're taking it in minimum dosage or you're taking
Yeah.
large amounts
What
of
we're
it,
trying to do is control symptoms and minimize side effects. Doesn't change the course of the disease, because the course of the disease is going to progress at whatever pace your genetics tell it to.
Yeah, Parkinson is in the late stage. How doctor or nurse practitioner dosage those Parkinson medications?
Sometimes depends on goals of their care. So there are lots of conversations about, we know that this is a terminal disease. Usually we're talking to the spouse, this is terminal disease, this is late stage, this is what we can predict. If you're having difficulty getting someone to take a med, and we doubt that there's a lot of benefit in it, then we may talk about stopping the drug. Families are very afraid to stop drugs. They think it's going to make it get worse faster, and it's just really hard to explain that it's going to go at the speed it's going to go no matter what we do. Yeah. Yep, progressive neurodegenerative disease. All right, because it's an ergot. Remember we saw ergot in migraines. What was the mechanism of action? Vasoconstriction. Migraines are right from vasodilation. It's a vasoconstrictor, so that tells us who we shouldn't use it in, right? Anyone with any type of vascular disease. Specifically, in this one, they talk about peripheral vascular disease, especially arterial. So I had a 97-year-old patient who smoked every day of her life and was clogged up. You look at her imaging and she's clogged up all the way. She has advanced peripheral vascular disease. Okay, if she had Parkinson's, this is one we would give to her because it's already blocked up. We don't want her to have necrosis in her limbs from no blood flow. Same type of issues with adverse effects. Anything that addresses bradykinesia, or anything that addresses a dyskinesia can cause a dyskinesia. Arrhythmia drugs are like that. Any drug that is used to treat an arrhythmia can cause an arrhythmia. Same thing with anything that is used to treat a movement-based disorder. There are some interactions, erythromycin, the class of adrenergic drugs. This doesn't get used very much. I'm not sure why. I think it's because we are worried that we're going to wear out or use up the ability of the body to produce more dopamine. I think that's the fear. Whether or not it's true, I don't know. Like we feel like it's a progressive neurodegenerative. If we whip the horse to run, or if we're pushing the body to produce more, are we going to progress the disease, or does it do nothing because it has that capacity now? I don't know. This is another non-dopamine dopamine receptor agonist, pramipexole, called Mirapex. This is a non-ergot, so we don't have to worry about vasoconstriction. We like it because we can use it in early and late stage Parkinson's. So if we use it in early stage, that may mean that we could wait a little bit to start the levodopa. Because we want to get the maximum benefit time, but not started too early. These are the drugs are all in the same family. Ropinirole, they're typically used for restless legs, but this particular drug, pramipexole, is more specific for Parkinson's type symptoms. And that's just telling you it's acting on dopamine receptors in the brain, both pre and post synaptic mechanism. All right, there's that same slide again, because we're going to talk about new drugs for the off episodes. All right, indirect acting dopaminergic drugs. God, another term, replacement drugs. So COMT is an enzyme that metabolizes levodopa and dopamine, right? So we saw that in the picture. COMT is an enzyme that metabolizes levodopa and dopamine. So is monoamine oxidase. So if we take a COMT inhibitor, right, we are inhibiting the enzyme that breaks down what we want. Awesome. great drug. So this is the one that shows up most often, this tolcapone. It's the first drug on the market, entacapone. These two, so again, same thing, look, GI upset, worsening dyskinesias. There is this weird urine discoloration that can happen of a dark urine. And it's that particular thing we have to keep an eye on because we worry if someone is going into kidney failure or liver failure. This tolcapone has been associated with liver failure. So it's easy to remember these Parkinson drug side effects of GI upset and dyskinesias, but this specific one is with liver failure. So there's the monoamine oxidase, right? So if we inhibit the enzyme that breaks down levodopa and dopamine, it stays in the synaptic cleft longer. And it's, yeah. So these newer drugs, this is MAOI. So that's the acronym for these drugs. There's a category of antidepressants called MAOIs, and they have very specific food restrictions. These drugs are related but not the same, so they don't have these food restrictions. And it gets confusing because when we talk about antidepressants, we'll talk about MAOIs, we'll talk about, oh, they can't have foods. Yeah. Just know that these are not the same drugs. They're more specific. So they are selective. These are the drugs I've seen most often, seledulin, misagiline. So we like this one because it's 10 times more potent. So it's kind of like the derivative, or I call it the pure stuff. Write the terms. This isn't pure. You want this one because it's pure. It can be by itself or with levodopa, lots of drug interactions. These are kind of the same types of involuntary movements. These are like anticholinergic, dry mouth, nausea issues, selective MAOIs. So recognize the names, recognize that it's used for Parkinson's as an add-on or by itself. And then this one, amantadine, originally came out as an antiviral for influenza, and incidentally found out that it was helping to control Parkinson's symptoms. So, you know, hey, maybe we can give you an antiviral and treat your Parkinson's. But this is used early in the disease, so early stages. So you can imagine someone may start out if they're early diagnosed on amantadine. That way we can delay levodopa. Then once it's lost its effectiveness after 6 to 12 months, then we might start them on Cinemet, which is carbidopa levodopa. Then if they're intolerant of symptoms, we may lower the dose and add on an adjunct drug. That's kind of the thinking between how all of these things work.
When you say it's a modulator, what does that mean?
Modulator, modulator. Oh, let me think how amantidine's mechanism of action is. Direct acting dopamine modulator. Coming back here. We were playing with receptors. I'd have to look it up. I've forgotten that. It's right back here. It's on a chip in my brain. It won't come out. Modulator. Oh, it'll be 2 in the morning and I'm going to spit it out. So side effects.
It's basically meaning it's where it imposes itself, where it takes a low frequency information and transfers it to a higher frequency. So if we're still talking about the neurons firing, it will take a low effective neuron, cause it to fire, or to
Amplify.
amplify
Yeah.
it to cause more.
That's not what I was thinking it was. Thanks for reading that. These do have anticholinergic side effects, and we will be talking about anticholinergics very soon, but the summary of those are these symptoms, like can't see, can't spit. What's that acronym? Anyway, so decrease, it's slowing everything up. It slows the GI tract, it decreases our secretions. It
Sludge.
causes us to retain urine. So those are anticholinergic side effects. Sometimes we use drugs for those effects, but in Parkinson's, it does have some ability to block symptoms from excessive cholinergic activity. So you may have acetylcholine, excessive acetylcholine floating around. So we may take something, an anticholinergic, to block that activity. So even though dopamine is the main mechanism of action, there are other factors involved. Just know that we use anticholinergics and what are the side effects of anticholinergics, which we will go over when we do anticholinergics. Noting it doesn't relieve the bradykinesia, those really slow their ability to start muscle action is slowed. So they have slow onset of muscle movement. All right, that's anticholinergic. These are some other drugs, probably. Yeah, I'm gonna say just recognize benztropine. That's an anticholinergic drug. There is a risk of too much anticholinergic activity called anticholinergic syndrome. Right, and then this is going to see if you need to make sure that you study to know which of the drugs is associated with postural hypotension. So what is postural hypotension?
Sudden drop of blood pressure, depending on the position.
While changing your position, right? So either from lying to sitting or from sitting to standing. And that one is associated with multiple drugs, but the only one listed up here was amantadine. So amantadine, cinnamon, propranolol. So those are things that are, the way that you would see that applied is they'll give you a patient scenario, they'll tell you a drug, and they'll ask you, you're providing patient information, and one of the options is to educate on changing position slowly, right? Very, very, like, do you know what are the adverse effects of these drugs? So somebody's getting a Parkinson's med and it's an anticholinergic, and anticholinergics slow things up. What do we teach them? Do we teach them to take it in the morning, to limit fluid intake? Tremors will be reduced within 24 hours. Don't take this with other meds. And generally speaking, it never happens in any sort of group living environment. The recommendation is not to take Parkinson's meds at the same time as any other meds on an empty stomach. But do you think that's going to happen if you're in an assisted living or in a nursing home? No, they get a cup of pills. Here's all your meds, take them. And we do recommend it taken at bedtime. That way, the initial, if you have postural hypotension, they're thinking you will be asleep when that might happen with the onset. That's the thinking. We don't restrict fluid. And this you definitely need to know. The time to onset of symptom relief can be days to weeks. So nobody's going to see an effect in 24 hours. It's more like, you may see an effect in a week, 2 weeks, 3 weeks, 5 weeks.
For hypertension?
For the effect of the drug, an anti-Parkinson's drug. They're slow onset. It's kind of like antidepressants. They take a while to get in your system, get to a therapeutic level, and to see a benefit. And then there's black box warnings. And then that's about all we have time for today.
Dr. Cardenas, can you publish this, please?
Yeah, I don't know. I must have